Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. So today we are going to have a mixed bag of things. There's been a couple of announcements made. This is the time of year when I get to catch up on all of my research, my reading, looking for articles and published guidance, making sure that we are heading into the fourth quarter appropriately. And there's been a lot of information out there that I think is something we need to look for as far as revenue cycle management updates. So here's one, and if you haven't signed up for Becker's Healthcare, their daily alerts, you can get anything from hospital, ASC, spine, clinical, health IT, CFO, dental, payer. They even have podcasts, behavioral health, physician. I like the payer issues, so I always look and see what's coming up on payer issues. And they just posted this week that United Healthcare launches prior authorization Gold Card Program, and here's 5 things to know. So it goes into effect October 1st, so last Tuesday. And the first thing, so providers will not have to apply for the Gold Card Program, but must meet certain eligibility requirements. So remember what this is. Again, this is a prior authorization program. So the requirements are they have to be in network for at least one United Healthcare commercial, individual exchange, Medicare Advantage, or community Medicaid health plan. They need to meet a minimum annual volume of at least 10 prior authorizations each year for 2 consecutive years across Gold Card eligible codes. So the program is a great idea, but now we've got some eligibility, some timeline situations, and I'm like, okay. Number 3 is they have to have a prior authorization approval rate. Now that's interesting, of 92% or more across all Gold Card eligible codes for each of the review years. So there's a lot that goes into this. You won't be automatically enrolled into the program. It also says providers that earn Gold Card status are required to complete advanced notification for services, but no clinical information will be requested. So it means you still have to do a pre-auth for the codes, it sounds like. The full Gold Card eligible procedure code list can be found at their website. Let me find it for you here. UHCprovider.com, and then go to content and then look for prior auth gold, and then you'll find it. And then what else did they talk about here? It's really just interesting, just some of the things that they put in here. And then they have number 4 is United Healthcare will conduct annual evaluations for Gold Card qualification. Gold Card status determinations are effective October 1st of every year. And the last thing they put in the program, it says providers may lose their status because of patient safety issues, failure to cooperate with quality and patient safety activities, failure to make timely responses to requests for information, or if they no longer meet program requirements. So even though this is a great option, if it was actually what I thought it was going to be intended for, make sure you read the fine print, because sometimes they'll say things and you're just like, wait a minute, I thought this was supposed to be a little bit more streamlined, and I'm not necessarily seeing that here. So a little bit, but not really what I kind of expected that it was going to be. So make sure that you do have that updated list and go to your UHCprovider.com to get that. Okay, so I was reading another article recently, and this just brought some things to my attention only because, again, fourth quarter, we have a lot of things that are becoming effective. We have ICD-10 codes that became effective on October 1st. And as I was going through a lot of the codes, and again, for the specialties that I work with, which are quite a few, I noticed that there's some subtle changes, not just massive overhauls, that we have to really pay attention to. You know, massive overhauls are easier to handle because you're like, okay, this whole section is going to be, laid out in detail. There's usually all kinds of different training and presentations and all kinds of things that you can find. But subtle changes can be sneaky, and this article was really nice from Angela Lima from Libman Corporation, and she wrote an article on this. And you need to really apply your coders, attention to detail, and realize that When you code diagnoses, or even if you're doing ICD-10 PCS, the procedural code system in the inpatient, that in the past, if for these little nuances, it may not be what you're doing in the future. So for example, and this was a good subcategory, so because I do gastro, so for anal and rectal fistulas, the K63 or K60.3 and then another digit to the K60.5 and another digit now actually have a, and I'm air quoting, quote, code first if applicable note added to each subcategory. So this means that a coder must follow the etiology or manifestation, the sequencing rules. So if the anal or rectal fistula's etiology, so where it stems from, is Crohn's disease or ulcerative colitis, I can't talk today, ulcerative colitis, so either K50 or K51 code section from those categories, they must be coded first by the manifestation code from the subcategories K60.3, 0.4, 0.5. And that could also have impact on the MS, DRG payment. So it's just important that when you are coding, that you look at the subtle changes, not just the big overhaul changes, because, as coders, we're the ones who have to pay attention and ensure that the coding is accurate and up to date. And sometimes it can't just be that you're waiting for codes to come out. Don't forget, you also have to update your tools and how you use them and what you depend on. Maybe your encoder, your coding education, even instructions from your organization need to be updated, that you don't even know how quickly they got things updated. So just make sure that you are, I get coders a lot of times that say, I'm one of those coders that kind of push back and just don't cause waves. But, the coders that are annoying and agitate for those updates, going, I need my updates to the encoder, those are the coders we need. Embrace that challenge, because your best defense for your organization is high quality data, and you don't have that unless you press to get this information, hopefully before its valid or effective dates, because that's where things can really make a difference when it comes to getting accuracy and things like that. So just know that I see some people concerned that, they get mad at me when I keep asking for my updates. But you know what? Let them get mad, whoever that they are, and say, look, things become effective October 1st and then January 1st, and I need some time to not only review but update my tools, update my staff. I need to be able to train. And these kinds of things are really important to get a handle on. And so if you don't have that handle, then you could be running into all kinds of problems and trouble. The CodeCast podcast today is also brought to you by Decision Health. Advance your coding career this November at the 2024 Advanced Specialty Coding Virtual Summits. Join top experts for cutting-edge insights in orthopedic, pain management, or anesthesia coding. Save $50 with code ASC2024 when you register now at codingbooks.com/events. So continuing with some revenue cycle management questions that have come up and concerns, the several Medicare administrative contractors came out with some of their outreach and education department for WPS, for GHA, for Novitas, and for Noridian. And they talked about some of their prepayment denials that have been really a problem. And so let me give you their top three here. It said, before we submit a claim with a new patient, 99202 to 205 office visit, make sure that no other provider of the same specialty or subspecialty in your group has seen the patient in the past 3 years. So you need to actually check in your system when the last encounter was for that patient, and you might miss it. And then if you try to bill a new patient, it'll say that this should have been established because it was in 3 years. And then not only will you not get paid for it, but it'll be tough trying to get anything paid once they see that that's a problem. And so you have to look at that original service first. Number two, they said, is more than one E&M for the same patient on the same day. Now, I've seen this come up because sometimes you may be providing multiple services within the same day. Maybe the patient did a virtual visit in the morning and you said, come in. When that happens, you have to combine those services into one E&M service, which means the face-to-face. You can't have two services on the same day, one virtual and then one in person. And you can only have one. If you base both of them on time, then it would be time. If you base them on medical decision making, then again, combined documentation. But remember, there is a virtual check-in that's out there, the G2012, that's been out since 2017. It doesn't have anything to do with telehealth COVID restrictions. But that means that the patient is established, they haven't been seen in the last 7 days, and you aren't saying, let's make the next available appointment. Once you say that, you can't even bill for that. You have to just basically say that, okay, I'm just going to bill for the office visit, because that's instead of coming in. But I've seen some practices that are trying to get away with billing a telehealth in the morning and saying, no, we need you to come in, and then trying to bill for two separate visits, and then you're going to get denied on both. So it's the total timed or total medical decision making of the combined services on that day. And then there's always bundling errors. You'll see it as advice remark code or remittance advice remark code CO-97. Those are usually global surgery denials. And this happens every once in a while. CGS administrators detailed this, saying that we get a lot of appeals and a lot of denials on this, because this is one of our top 5 modifier coding errors. They said that basically, a lot of providers' offices, they don't know their payment policies. They don't understand that if you see a patient or if you perform a global service, then you can't bill for an office visit if it's a related diagnosis. So the patient, had an appendectomy and they're coming back in for a little bit of abdominal pain, checking the wound site. They're not quite completely healed within 30 days, 60 days. There's nothing extra to bill. That's just the normal recovery time. But if the patient, let's say, comes back in a month, they check their wound site, everything looks good, and say, you know what, I'm also having some breast pain and I think I felt a palpable mass, then that would be a 24 modifier, an unrelated evaluation and management service during a post-op period by the same physician. But you see the difference in contrast there. It's not related or the same symptomatology that you would have from the major procedure. So it's just so important to make sure that you understand the rules before you send things out with your revenue cycle management. I think one of the biggest rules that people don't understand is when you're trying to bill for an established office visit or even new office visit in a preventative medicine. Remember, if the patient's coming in for a preventative medicine and they have a problem significant enough that you need to do a complete workup for them on this complaint, where it requires data points, it requires possibly ordering tests or ordering diagnostics or setting up treatment, under the assessment and plan, then you can bill for both with a 25 modifier on that office visit along with the preventative service. But if they're coming in for an office visit and they say, why I'm here, can we also do my female well check? No. You can, but it will be out of pocket for a patient, because that's not how that works. It's not in reverse. Because they're not well. They're coming in for a sick appointment, as I call them, or problem-oriented service. So how can you bill for a preventative well check? You can't. If they're there for a well check and, oh, by the way, I have this problem, again, significant enough to work up, then that may warrant 2 visits. But you can't do it in reverse, and I see that denial quite a bit. So then when we look at post-payment recoupments, so front-end claim denials of E&M service, catch problems with information before you submit that claim. But post-payment reviews, such as when we see those TPE audits, targeted probe and educate, they tend to uncover problems with documentation as well. And sometimes these can go undetected unless, for example, I'm an outside auditor, so I look at them, and I've seen them accumulate for years. I was doing a recent audit for First Coast Service Options and Novitas, and they were talking about their reports and just what their audit was looking at. And they said, it's amazing to me, the findings, not just you, as a payer auditor, but just what we found from our other auditors. And a lot of it is their number one thing they say, providers submitted documentation that did not meet the medical necessity requirements of Medicare coverage. And then they said documentation did not support the medical necessity for the reported level of service or decision making. And providers are downcoded when they feel that they're trying to upcode their claims. And then it also says documentation not support the level of the practice built. See, this seems redundant to me. And then they say documentation not support the E&M, the service that was billed. I'm like, well, that's the same thing. And they said, well, yes and no. So it's funny how they use the same wording, but they list it as 1, 2, 3, 4, 5. And the last one, and this is always a big one, the documentation did not support billing the incident to physician services. And so you need to be up on that as well. But really make sure that your staff is trained, not just on compliance, but using the current Medicare's rules for documenting and reporting E&M visits. Go to CMS, it's the chapter 30.6, chapter 12, and it is CMS 100-04, and it's on the CMS Medicare Integrity Manual online. But it's amazing to me that a lot of practices don't look at that and then also don't follow guidance from their MAC carrier, their Medicare administrative contractor, because a lot of individual carriers, I know in California we have Noridian, and boy, they have very specific documentation requirements with regard to signatures, with regard to incident to and medical necessity that I don't see on a lot of other MAC sites. So always know when we're dealing with the RCM, especially with what we dealt with Change Healthcare and dealing with that nightmare, you just want to be above scrutiny because we don't want to go through that again. We don't want you to have a cash flow problem. We just want to make sure that you're going to continue to be viable before there's ever an issue. Okay, that's it for me today. Just a personal little tidbit. I am soon going to be in Hawaii for a week with my husband, so I may be doing my next podcast live from Hawaii, so I'll definitely let you hear the ocean in the background, but that'll be a fun trip for us, celebrating our 25th, and also my birthday's that week, so it'll be just a fun trip. We haven't been able to be back. Last year we didn't get to go, but I've always spoken for AAPC, and actually I'm doing a virtual meeting, AAPC Hawaii, but they haven't been able since COVID to get back in live for their conference only because of the cost of hotels. So it's always fun to go out there and to be able to see people. But everyone, I hope you have a good rest of your week. Make it a great day, and thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.